കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു, കാരുണ്യത്തിൻ നിറകുടമായി. രാത്രി മുല്ലകൾ പൂത്ത സുഗന്ധം പോൽ നമുക്കൊന്നായി ചേർന്നിടാം, നമുക്കൊന്നായി ചേർന്നിടാം. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു, കാരുണ്യത്തിൻ നിറകുടമായി. കനിവു നിറഞ്ഞാടും മാമലനാട്, സുന്ദര കലകൾ തന്നാട്. ജാതിമത ചിന്തകൾക്കപ്പുറം എന്നും മാനവനൊന്നായ നാട്. ഈ നാടിനുയിരായി നീങ്ങാം, ഒന്നിച്ചൊന്നായി നീങ്ങിടാം. ഈ നാടിനുയിരായി നീങ്ങാം, ഒന്നിച്ചൊന്നായി നീങ്ങിടാം. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു, കാരുണ്യത്തിൻ നിറകുടമായി. നിറദീപമായെന്നും അണയാതെ കാത്തിടും നമ്മൾ. ഒരുപാട് ജന്മങ്ങൾ, ഒരുപാട് യാതനകൾ, അതിലെല്ലാം താങ്ങായി സ്വസ്തി. സ്വസ്തിതൻ കരങ്ങൾ തൻ സ്നേഹത്താൽ നീറുന്ന ജന്മത്തിനാശ്വാസമായി. സ്വസ്തിതൻ കരങ്ങൾ തൻ സ്നേഹത്താൽ നീറുന്ന ജന്മത്തിനാശ്വാസമായി. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു, കാരുണ്യത്തിൻ നിറകുടമായി. രാത്രി മുല്ലകൾ പൂത്ത സുഗന്ധം പോൽ നമുക്കൊന്നായി ചേർന്നിടാം, നമുക്കൊന്നായി ചേർന്നിടാം. കരുണതൻ നിറവോടെ ഞങ്ങൾ വരുന്നു, കാരുണ്യത്തിൻ നിറകുടമായി. ആ
Welcome to the IRIA Preventive Radiology National Program. Welcome all delegates and faculty to the IRIA National Radiology Preventive Radiology National Program. It's a part of the Kerala Cancer Crusade and the Cancer Literacy Mission, a program, a project, 8-year project that has been envisaged and jointly supported by several stakeholders in cancer care and cancer prevention. Indian Radiological and Imaging Association Kerala and the Preventive Radiology Wing of the National IRA is a part of it, and it is in association with the Susti Foundation and the Community Oncology Department of Regional Cancer Center. We are having a webinar series, and today it's the third day we will be discussing on the cancer cervix. So if you look at the cancers in Kerala, especially in females after breast cancer, it is the CA cervix or the cancer of the cervix, and the gynecological malignancies are the highest in number. So it is time for us. The Cancer Crusade is a campaign not just focusing on cancer treatment or the palliative care. It is focusing on cancer prevention and modification of risk factors. So we need to work towards a goal of identifying those high-risk groups and also to detect the cancers in an early stage. That's a downstaging of cancer so that the quality of life is better and the survival rates also significantly improves. So with this intention, there has been several programs started out all over Kerala, and as an awareness campaign, and to bring the very important stakeholders in this campaign, that is the doctors of all specialities and including the general practitioners, because one thing that I've observed is many people who have been detected with breast cancers or the advanced stages of some of the malignancies, they might have seen the general practitioners or physicians or surgeons at some point of time, especially in Kerala. But there is no focus for a NCD screening or for a cancer screening in the facilities available, and they might have gone to a physician or a GP who is not having a orientation towards a screening programs on cancer. So this is very much essential for us to bring in that awareness and to have a kind of programs that has to be instituted in the amongst the medical community at different levels of healthcare. So today we have a speaker, Dr. Remya Binish, who will be talking to us on a very interesting topic, magic numbers 90, 70, 90 in cervical cancer prevention. But before going to our academic session by Dr. Remya, I would like to invite Dr. Praveen Nirmalan, a researcher and chief research mentor at Amma Healthcare Research Gurukul and Amma Center for Diagnosis and Preventive Medicine, Cochin, who is from the Johns Hopkins School of Medicine, did the research fellowship, and has helped researchers in all over the country in different specialties. May I invite Dr. Praveen Nirmalan to give the presidential address.
Thank you, Dr. Vijay. So I would like to thank the Preventive Radiology Initiative of IRIA for considering such a program that focuses on the preventive aspects. And usually when we think of radiology, we don't look at it or consider it as a preventive subject. It's more like an imaging clinical subject, supplementing the clinical findings. There's nothing that is coming out as preventive in the way it's being practiced now, for most parts. And this is a new initiative that has been conceived by Dr. Vijay and brings out several elements of imaging that are pertinent towards a preventive aspect of clinical medicine. And so I would like to thank the IRA for having such an initiative. I would like to thank Swasti Foundation for starting a Kerala Cancer Crusade. Kerala is having a very high magnitude of cancers due to several reasons. And it's important that we have a Cancer Crusade in Kerala. I'd also like to thank, even though they have not started speaking, I would like to thank the speakers for agreeing to speak on important topics as part of the series, and especially today. The cervical cancers is an important topic, and it's quite strange that a male is going to talk or give a presidential address on cervical cancers. Quite unfair, I feel. But anyway, that's the way the dice rolled. It's a cancer that has got several aspects, even beyond the aspect of the tumor or the cancer itself or the pathophysiology. It's also an indicator of inequities and inequalities in healthcare distribution and access to care across the world. And that's why we see that most of the cervical cancers are in the low and middle income countries. But a lot of the data, or most of the data, comes from the high income countries. And that is a strange paradox that we face. And it's not limited only to cervical cancers. It's limited to many conditions, many diseases, where we find that much of the data, much of the evidence support, much of the protocol development, much of the target and goal setting comes from high income countries. While a lot of the targets that are to be achieved, a lot of the work is expected to be done in the low and middle income countries. Now, the WHO has set up the 90-70-90, which Dr. Ramya will talk about. And that was a good initiative. That was a good set of goals that were designed, and with targets set for 2030, and with cost and mathematical modeling showing that if we achieve these targets by 2030, we can have a very significant reduction in the magnitude of cervical cancers by 2040. And the reason for that is that there's a time gap between the screening and the onset of the cancer. And from an Indian perspective, Indian epidemiological perspective, much of the cervical cancer is found initially at 55 to 59 or beyond 50 years. Well, the screening is at 35 and the second screening is at 45 years. As we look at these targets and we look at the process, there are several things that I feel are important, and I'm sure that the speakers will consider and explain. One is a deeper understanding of the risk factors. We know several risk factors from the personal risk behaviors, from the developmental aspect, including age at marriage, including multiple sexual partners, personal hygiene, things like that, which takes a long time to change. We know we have a therapeutic, or sort of therapeutic intervention, if we call it, the cervical cancer vaccine. And we know that it works against certain viral strains. And we have also seen that the viral strains, although they are slightly different between North and South India, the vaccine works reasonably well. And the vaccine gives you a pathway to start a preventive program, even as we work on the developmental and other aspects of risk factors of it. We also need to look at the distribution of risk factors. We need to consider, how do we roll this out? Do we look at a mass screening program? Do we look at a high-risk targeted program? What's the approach that is optimal for a population that's as diverse and in a large country like ours? Most importantly, I feel that we need a lot of data support to come in, to build evidence from our own setup, to build evidence from our own population, to see if we need to refine any of these processes, protocols, targets as appropriate for our country. And one lacunae that is there in our healthcare setting is the lack of sequential or follow-up data, except from certain centers or tertiary care centers. So once we go and do a screening program, and we know that the cancer will develop much later and changes develop much later, do we have sequential, do we have a protocol or a process in place for collecting sequential data? That's a big lacunae. That's not relating only to cancer. It's a big lacunae in many conditions, chronic diseases, where we need longitudinal data and longitudinal analysis. So it comes from tertiary care centers. It comes from advanced care centers. It comes from regional cancer centers. It comes from registries. It comes from some screening camps. But we also need a process where we involve the primary physicians, where we involve the secondary care physicians, where we involve people at different levels, so that we get a better understanding or broader understanding of it. And as cervical cancers is one area where we have the potential to involve primary physicians, we have the potential to involve secondary care physicians with the screening, with the follow-up, with the assessments, and to add on to the wealth of information that we get from tertiary care centers. The other aspect with cervical cancers, as with most cancers and even with many chronic diseases, is the aspect of what testing do we use for screening, and how effective is that, and what is the level of efficacy and efficiency of those testing protocols within an Indian population. So even if you're using a pap smear or you're using something else, we are doing a direct visual inspection. How does it perform? How does it work in real life practice across multiple settings? So these are aspects that I think are important, even as we look at the therapeutic interventions and the therapeutic pathways that go on, and these feed into it. And I'm sure Dr. Ramya is staring at me. I'm sure Dr. Ramya will give a good talk on this topic. And I'm sure Dr. Gina and Dr. Danya will add a lot of value. Dr. Kalavati will add a lot of value to the discussions that happen around it. And with that, and with profound grief that a male was invited to give a presidential address on cervical cancers, I open the floor to the esteemed speakers.
Thank you, Dr. Praveen Nirmalan. That was the Chief Research Mentor of Amma Healthcare Research Gurukul. Thank you once again. Now, let me introduce the chief guest of the day, Dr. Gina Baburaj. Dr. Gina is the chairperson of the Oncology Committee of Kerala Federation of Obstetrics and Gynecology, and also the state coordinator for the Oncology Committee of FOXY. She is a consultant gynecologist at CM Hospital, Vadagara, Kozhikode, and has got and the field of interest include obstetric gynecology, sound colposcopy, and infertility. Dr. G, the role of gynecology is very, very important, especially almost all these women cancers and women breast imaging, breast cancers, and all the gynecological malignancies. It's a very important stakeholder. And no wonder Dr. Gina has taken the lead in promoting the cancer screening programs, especially for CS cervix and gynecological malignancies. We are fortunate to have Dr. Gina here with us as our chief guest. Let me invite Dr. Gina to give the address to this august audience. Over to you, Dr. Gina.
Good evening. Thank you, Dr. Rijo, for the kind introduction. Respected Dr. Praveen Nirmalan Sir, Chief Research Mentor, Amma Healthcare's Research, Gurugal, Kochi and Hyderabad. Dr. Rijo, the Secretary. Dr. Danya K.S., the Consultant Radiologist, Baby Memorial Hospital. Dr. Kalavati, Associate Professor, RCC, and Speaker, my friend, Dr. Ramya Binesh, and Gynecologist, Asterman's Hospital. And officials of IRIA, senior members of the profession, and all those who are logged into the webinar. I am extremely happy to be associated with this wonderful function, which is being organized as a part of Kerala Cancer Crusade and Cancer Literacy Mission, IRIA Preventive Radiology National Program in association with IRIA Kerala, Swasti Foundation, and Community Oncology Regional Cancer Center. Prevention is the cornerstone of any health activity. Cervical cancer is a preventable disease. It is also curable if detected early and treated adequately. But still, it is the fourth most common cancer among women worldwide and the second most common cancer in India. And India contributes about 1/4 of the world's cervical cancer-related mortality. In Kerala, cervical cancer is the third leading cancer, with an incidence of 6.8 per 100,000 population. 15 years back, elimination of a cancer was only a dream, but now we have cost-effective, evidence-based modalities to eliminate cervical cancer. And for the first time in the history of modern medicine, WHO has committed to eliminate a cancer. Fortunately, it is cervical cancer. In November 17, 2020, WHO has officially launched the cervical cancer elimination strategies, which is to be achieved before 2030. The strategy can be summarized as 90-70-90. HPV vaccination coverage to 90% of eligible girls, 70% eligible women should undergo screening with a high performance test, and 90% of women with a positive screening test or cervical lesion managed appropriately. By achieving this, we can eliminate cervical cancer. We have to achieve this before 2030. That is our goal. The launching event represents a historic milestone because it is for the first time 194 countries commit to eliminate a cancer unanimously. We can feel proud that the fact that India is one among them. We all know that the primary cause of precancerous and cancerous cervical lesion is infection with a high-risk oncogenic HPV virus. Till now, 14 high-risk HPV types are identified. Out of these, HPV 16 and 18 are responsible for about 70% of cervical cancer globally, but in India, it is more than 85%. Vaccination of adolescent girls is the most effective intervention for reducing the risk of cervical cancer. There is strong evidence that high HPV vaccination coverage leads to protection of unvaccinated individuals through herd immunity. Most of the countries included HPV vaccination in their national immunization schedule. Our neighboring countries like Sri Lanka, Bhutan, Myanmar, Thailand, they all included HPV vaccination in their immunization schedule. In India, Punjab, Sikkim, and Delhi have included this vaccination in their immunization schedule. Kerala state is almost always in the forefront in taking necessary steps to protect the health of our people. But unfortunately, we are waiting for the good news. The government is yet to take a decision. Recently, Made in India HPV vaccine, Servavac, was introduced After conducting large multi-center trial, the vaccine was found to be affordable and highly effective and safe. It will be made available soon. Coming to the screening, currently there are 3 methods: cytology, VIA, and HPV test available for cervical cancer screening. Cytology and VIA tests are relatively subjective with an average sensitivity of around 50%. HPV testing is highly reproducible, objective, mechanically measured, and has a very high negative predictive value. Most of the international guidelines recommends HPV testing as a primary screening modality for cervical cancer prevention. We have to do an organized screening program to reduce the incidence of cervical cancer. Unfortunately, we don't have an organized screening program. In Kerala, Oncology Committee KFO initiated a project last year called Fight HPV, Let Us Make Cervical Cancer Free Kerala. We have conducted initial webinars on cervical cancer prevention in all the 12 Foxy societies of Kerala to sensitize the gynecologist. As a result, we are able to conduct more than 100 public awareness programs, including webinars, classes, then writes up in magazines, newsletters, YouTube videos, WhatsApp messages, short films, flash mobs, beach walk, TV talks, messages in FM radio, etc. So in all methods, we propagate this message to the cervical cancer prevention strategies to our society. And we have conducted vaccination drive to all medical colleges of Kerala, both private and government, and also schools and arts and science colleges, so that our HPV vaccine utilization increases dramatically. Before 2021, the HPV vaccine usage was only 40 to 50 vaccines per year, but now it is 150 to 200 per month. So it is possible with the effort of all the KFO gains. Coming to cervical cancer screening, the KFO Oncology Committee have conducted HPV screening to all eligible KFO members and their spouses in 2021. We also initiated VIA-based screening program in Kozhikode district in association with Calicut ONG Society and NHM. And we have already conducted webinars for ASHA workers, VIA training to JPHNs, and colposcopy workshop to gynecologists of Calicut district. So if we all work together, we can achieve cervical cancer elimination in Kerala well ahead of 2030. Let me thank the organizers for giving me this opportunity. With all of your permission, I declare the webinar inaugurated. Thank you.
Thank you, Dr. Gina Babura. That was the chairperson of the Kerala Federation of Obstetric and Gynecologist Committee for Gynec Oncology, and she is coordinating the national mission of the gynecologists as Foxy for the gynec oncology also. So thank you, doctor, for the wonderful message that you've given, and we would like to continue to have the Association of Gynecology Society as well as the Gynec Oncology Committee in our endeavors to continue with the Kerala Cancer Crusade and Cancer Literacy Mission. Thank you very much. Now we will move on to the talk, the scientific talk of the day. The speaker is Dr. Ramya Binesh. She will be talking to us on already. Dr. Gina has talked about 90, 70, 90, the magic numbers in cancer, in the prevention of cancer cervix. And Dr. Ramya Binesh will be talking to us in detail about this campaign. And Dr. Ramya Binesh is a consultant in obstetrics and gynecology in the Aster MIMS Hospitals, Kottakkal, Kerala. And she has a winner of the Best Young Talent Award in 2014 by KFOG and has presented multiple papers and is a regional coordinator for the Kerala Federation of Obstetric and Gynecology Oncology Committee and her special interest in gynec oncology. After this talk, we will have a short panel discussion, and the panelists here, I have got a radiation oncologist, Dr. Danya KS from the American Institute of Oncology in Baby Memorial Hospital, Calicut, and Dr. Kalavadi ma'am. She is an associate professor in the Community Oncology Division of the Regional Cancer Center, Trivandrum. And along with me to moderate this session, I have the additional professor of Community Oncology, Dr. Jay Krishnan, also with me to moderate this session. So before that, Let me invite Dr. Ramya Binish to deliver her address. Over to you, Dr. Ramya.
Thank you, sir, for that introduction. And so, good evening, everyone. Gina Madam, Praveen sir, Kalavati ma'am, and my dear friend, Dr. Danya. She's my colleague and my classmate. So I'm very happy to be here. I'm very happy to be a part of this webinar. At the outset, I would like to thank my dear colleague, Dr. Avani, for inviting me for this webinar. Unfortunately, she's not here because of her health issues. So I think Gina Madam and Praveen sir has made my job simple because they have gone through all the aspects of cervical cancer. I just need to add something more. That's the only thing I need to do today, I think so. So I will start with sharing my screen. So when I was asked to present a topic in preventive oncology, I didn't think twice because being a gynecologist and a gynec-oncologist, I would be more interested to talk on cervical cancer because cervical cancer is something which is totally preventable. It is one of the deadliest cancers, but it is totally preventable. So over the past 2 years, Gina Madam has already told we have been conducting a lot of activities for the prevention of cervical cancer. We have been doing a lot of academic programs. We have been doing a lot of screening camps, HPV vaccination campaigns, etc. She is a very vibrant leader, and under her leadership, we have been doing a lot of activities for the KFOG. All over the world, as already Gina Madam has told, around 194 countries. They all have come together and to fight against cervical cancer so that it ceases to be a public health problem in the near future. So the first time ever, the world has committed to eliminate cervical cancer. So I'll be talking on the magic numbers. I'll be concentrating on the magic numbers 90, 70, 90 in cervical cancer prevention. So let us come to the topic. So coming to the global perspective of cervical cancer, it is the 4th most frequently diagnosed cancer, and it is the 4th leading cause of cancer death in women. Around 604,000 new cases and 342,000 deaths have been detected, have been reported worldwide as of the Globocon data 2020. But we can see that the incidence and mortality rates have declined in most areas of the world for the past few decades, maybe because of the improved socioeconomic status, the reduced parity, reduced prevalence of STD, and because of the screening programs that have been conducted very effectively all over the world. Coming to the Indian scenario, around 123,000 new cervical cancer cases and 77,000 deaths have been reported from India, and cervical cancer ranks second among the women cancers. So it accounts for nearly 18.3% of the total female cancers. But India also shows a decline in the incidence of cancer, cervical cancer by 1 to 2% per year, but this is very low. When we compare with the developed nations where they are having very well structured screening programs, they are able to reduce the incidence of cervical cancer by nearly 75% over the past 50 years. But where we are standing that we should see. And we see that the incidence of cervical cancer in Kerala is 7 per lakh compared to 14.7 per lakh in India. So in India, this is being a totally preventable disease. We are quite unfortunate that we are having a very huge burden of disease. Nearly 20 to 25% of the total burden of the disease is from India only. So the thing is, we don't have a structured screening program, nor we don't have a vaccination program for fighting against CS cervix. And as already Praveen sir told, there is a gross inequity in the distribution of the facilities. It is not available to the most needy population. And the cervical cancer is something which is more commonly seen in the low socioeconomic status group because all the risk factors are more seen in this particular category of people. So 99% of the cervical cancers can be attributed to a single virus infection. It's a human papilloma virus. It's a double-stranded DNA virus. It is a sexually transmitted disease. So more than 200 genotypes of HPV have been identified. Of these, 12 to 14 belong to the high-risk types, which are responsible for cancer, as well as the precancerous changes. And of these, more than 85% of the cervical cancers is caused by two genotypes of HPV, that is the HPV 16 and 18. Along with that, we have this HPV 6 and 11, which is responsible for more than 100% of the anogenital warts. In addition to the cervical cancer, HPV is responsible for more than 90% of the anal cancers, 70% of the vulvar cancers, 70% of the oropharyngeal cancers, more than 60% of the penile cancers in the males, and more than 75% of the vaginal cancers. So if you are able to avoid the HPV or prevent the HPV infection, of course, we'll be able to reduce all these incidence of all these types of cancers. So coming to the natural history of the disease, it's a sexually transmitted disease. Once it infects the cervix, at one point of our lifetime, that for every sexually active men and women are likely to contract this infection at one point of their time. But luckily, 90% of the individuals will be able to eliminate this infection by their immune response. But in 10% of them, this infection is going to persist. And if it is persisting, then there is a chance that it can progress to precancerous lesion and then to cancer. So if the lesion is persisting, if it becomes a precancerous lesion, then depending upon the grade of the lesion, if it is a low grade lesion, then there is a high chance that it will regress back. But if it is a high grade lesion like CN 2 or 3, there is a high chance that it can progress to invasive cancer. So this slide is adopted from WHO. This is a life course. This is a life course approach to cervical cancer prevention and control. We have seen there are 3 modes of prevention available for fighting cervical cancer. For the primary prevention, we have the HPV vaccination, which is advised for the girls between 9 to 14 years. Along with that, we promote the improved sex education, condom promotion, male circumcision. Then for secondary prevention, for women more than 30 years of age, we have the screen and treat approach where you screen the patient at the same time you can treat using the VIA approach and all, which we do in the low resource settings. Then we have the point of care rapid HPV testing for high risk HPV types, followed by immediate treatment and on-site treatment. And for tertiary prevention, for all women as needed, treatment of invasive cancer at any stage and treatment of the precancerous lesions. So coming to the primary prevention. So how the vaccine is synthesized? The vaccine is synthesized using the HPV L1 virus-like particle. This is actually a very novel vaccine strategy where the DNA of the virus is not incorporated. Instead, we take the L1 gene of the HPV DNA and then insert into the plasmid, and then we get the empty viral capsid. So a live virus is not incorporated in the vaccine. So the vaccine, in that aspect, it is very safe. So it is found that the immunity consequent to vaccination is 1 to 4 logs higher than that acquired after a natural infection. So the vaccine is found to be very effective. So what are the types of vaccines that are available as of now? We have three types of vaccine as of now available. First one is the bivalent vaccine, which is a Cervarix, and which incorporates or which is active against the HPV genotype 16 and 18. Then we have the quadrivalent vaccine, which was approved in 2006. And it incorporates the genotype 6, 11, 16, and 18. 6, 11, it protects against the anogenital warts also. So it is recommended in males also. Then we have the recent one, which is introduced, which was approved in 2014 and now recently available in India, which is active against all these 9 types of HPV. So these are the 3 types of vaccine. The first one is the Cervarix, second thing is the Gardasil 4, and we have the Gardasil 9. So the contraindication to the vaccine will be pregnancy. For this HPV vaccine is not recommended as of now. It is not recommended in pregnancy. But if you have accidentally given the vaccine in pregnancy, there is no issue. None of the studies have documented any adverse effect in pregnancy. But as of now, it's not recommended in pregnancy, and it is contraindicated in those who are having hypersensitivity to yeast or who had reaction to the previous doses of Gardasil. And it can be given either as a 3-dose series or a 2-dose series, and that I will come to that later. So everyone will be concerned of the efficacy of the vaccine. We have very big trials which have been conducted over based on this vaccine all over the world. We have the prominent Future 1 and 2 trials, and we have the Patricia trials. And all these trials have been conducted in thousands of women. And what they have found is that there is 98% efficacy in preventing cervical precancers. And this vaccine is effective and 44% efficacy in all women, irrespective of the baseline HPV status, irrespective of whether they are infected or not. And the Gardasil is found to be 100% efficacious in preventing vulvar and vaginal precancers and genital warts. And the Cervarix has offered cross protection against the other HPV subtypes at 31, 45, and 52. And the next thing about the vaccine is the safety of the vaccine. So this is the Global Advisory Committee on Vaccine Safety, which statement on safety of the HPV vaccines, which was published in 2015. The VCS has systematically investigated the safety concerns raised about HPV vaccine. They have issued several reports in this regard, but to date, it has not found any safety issue that would alter its recommendations. These are the common side effects associated with HPV vaccination. These are all minor side effects and which can occur with any type of any other type of vaccines. And one of the most common side effect that we see is the syncopial attack, and that can be averted if you ask the patient to sit down for some 15 to 30 minutes after vaccination. That can be averted. So all these are very minor side effects, and the CDC is constantly monitoring the side effects of the vaccine using all these reporting systems. And so as of to date, there are no safety concerns have been raised against this vaccine. So what is the recommendation from the FOGSI? The Federation of Obstetrics and Gynecological Society of India recommends HPV vaccination. So they have recommended these two types of vaccines, and now the nonavalent vaccine has also become available. This was published in 2018. And the vaccine is licensed for use in India from 9 to 45 years of age. And the target age group will be 9 to 14 years. And if you're giving the vaccine below 15 years, that is in the target age group 9 to 14 years, you need to give only 2 doses. And from 15 to 15 years and above, we need to give 3 doses. So, and the interval will be, if you are giving 2 doses, you give at 0 months and at 6 months. So second dose may be given at 5 to 15 months. And for 3 doses, we give at 0, 1, and 6 months. So it's necessary that you have to cross 4 weeks. There should be at least 4 weeks interval between the first and second doses, and at least 12 weeks interval between the first and third doses. Then catch-up vaccination. We can also vaccinate in this particular age group, but ideally the vaccine should be administered before the onset of sexual activity, because if you are infected with one strain of HPV, the vaccine is not going to protect at that particular strain. So that is why in the older age group, we have to counsel the patients that this vaccine will be having reduced efficacy, because it will not protect against those strains which have already been infected with. So what is the current status of HPV vaccination in India? Cervical cancer prevention efforts. Actually, the bivalent and quadrivalent vaccines were licensed in India in 2008. But we had started HPV vaccination demonstration projects in Andhra Pradesh and Gujarat. But unfortunately, 7 deaths were found out in the vaccines. But these deaths were actually totally unrelated to vaccine, but it was falsely labeled as consequent to vaccination, and and the vaccine had its initial setback at that point of time. So at that point of time, Government of India suspended the HPV vaccination in the research studies, but it continues to be available for prescription. But later, all these problems have been cleared, and in 2016, the Delhi government, along with the Punjab and Sikkim government, has started vaccinating their girls. So that is the status of HPV vaccination as of now in India. Now we have the nonavalent vaccine available, and we have our own indigenous vaccine available, and it has got approval, and it will be available at least by the end of this year. So between 2006 and 2017, nearly 100 million adolescent girls received at least 1 dose of HPV vaccine, but 95% were in the high-income countries. Only less than 25% of the low-income countries have introduced the HPV vaccine into their national immunization schedule. We also don't have this vaccine in our national immunization schedule, and the most important factor is its huge cost, because we need to import this vaccine. And because of a huge population, it might not be possible for the government. But luckily, we have our indigenous vaccine that has been developed by the Serum Institute of India as a Servavac. Once it is available, the vaccine will be available at reduced cost. So currently, the dose of 1 dose of Servarix cost around 2,500 rupees, and 1 dose of Gardasil cost around 3,500 rupees. So if you are Servavac, what Punanwala has offered is that you will be able to get the vaccine at a rate of at least 200 to 400 rupees. So fortunately, it might happen at the end of this year, and by that time we'll be able to include this vaccine in our national immunization schedule. So that is about the primary prevention. Then we come to the secondary prevention. So what are the screening methods for carcinoma cervix? We have 3 methods available. One is the HPV DNA testing, which is considered as the gold standard by the WHO. Then we have the pap smear or the liquid-based cytology, which was the conventional screening test that we used to do. And then we have the VIA or VILI, that is visual inspection with acetic acid or visual inspection with leukocytin, which was commonly used which was suggested in the low resource settings. So as of now, HPV DNA testing is the gold standard, because it is this test which is having the maximum sensitivity. So how often you should do the screening? This is a recommendation from the Federation of Obstetrics and Gynecological Society of India, the good clinical practice guidelines. So they have clearly recommended what tests should be given based upon the availability of the resources. So if it is a good resource setting, then we should always do the standard or the gold standard test, which is the HPV DNA testing. Either you can do the primary HPV testing or co-testing when you combine it with cytology, or you can also do the cytology if your lab meets the quality standards. Then colposcopy, biopsy, and VIA will be suggested in the good resource settings. But in limited resource setting, VIA will be better, and because it can be done by the trained personnel. Doctors may not be required. Even the ASHA workers or any other trained workers will be able to do the VIA so that they can get any early referral. Then what is the target age group for screening? It will be from 25 to 65 years. If you do by cytology, you start at the age of 25. And if you do with the HPV, primary HPV testing and co-testing, then we start at the age of 30. Primary HPV testing is not recommended below 30 years because the incidence of or the prevalence of HPV infection in this particular age group is very high. And that is why we need to do HPV DNA testing only from the age of 30. And VIA, we recommend to do, start screening at the age of 30. And when to stop screening, we stop screening at the age of 65, provided they are having 3 consecutive negative samples. But if you find a lady at the age of 65 who have never done a screening, you have to do a screening at that point of time using the high performance test. And if it is negative, she can quit the screening. And how frequently you need to do the screening? If you're doing screening with the primary HPV DNA testing or co-testing, you need to do every 5 years, because primary HPV testing is something which is very sensitive. And therefore, if it is negative, you can assure her that at least in the next 10 to 15 years, she's not going to develop a high-grade lesion or a cancer. And cytology, because it is something which is having less sensitivity, and therefore a cytology you need to do every 3 years. And for VIA, it is suggested to do VIA every 5 years, so that we will do it at least 1 to 3 times in a lifetime. So how will you choose the most appropriate screening test for our practice? So in our, that means in our routine private practice or whatever it is. So if you presently screen by cytology, and if your lab meets all the quality indicators, then but if you are having you can afford an HPV DNA testing, then it is better to switch over to HPV DNA testing. Else, you can continue with your present screening with cytology. But if you don't screen with cytology, then you cannot afford HPV DNA testing, then it's better to go with VIA. And if some abnormality is detected, then we go with the colposcopy and biopsy. Colposcopy means we are looking at the cervix. We paint the cervix with the leukocyte and acetic acid. We find the abnormal area and then do a directed biopsy. Instead of doing a blind biopsy, we always suggest doing a directed biopsy. And of course, ablation or excision at the same sitting in the screen and treat or see and treat approach can be done whenever feasible as per the criteria, because we often lose the patients whenever you diagnose with something, then they may not return back. So to avoid that, we have the option of giving a screen and treat approach. That is, you screen at the same time you treat also. So one woman dies of cervical cancer every 2 minutes, and each one is a tragedy, and you can prevent it. So these are the words from Dr. Tedros Adhanom Ghebreyesus, who is the Director General of WHO. And in May 2018, the WHO Director General has announced the global call for action for eliminating cervical cancer. In November 2020, the World Health Assembly adopts the global strategy to accelerate the cervical cancer elimination. So these are the magic words that have been put in my presentation slide. 90% of the girls fully vaccinated with HPV vaccine by the age of 50, and 70% of women screened using a high performance test by the age of 35 and again at the age of 45. So you need to do at least by the age of 35 and by 45 using the high performance test, that is HPV DNA testing. And 90% of women identified with cervical cancers receive proper treatment, be it a precancerous lesion or a cancerous lesion. She has to be properly managed. So these are the magical words or the magical numbers in cervical cancer prevention as advised by the WHO or the World Health Assembly. So by achieving the targets by 2030, what you will be able to achieve? You will be able to reduce the mean cervical cancer incidence rate by 10% by 2030. 70 million cases could be averted by 2120. 62 million cervical cancer deaths could be averted by 2120. So in the meantime, implementing this strategy is going to save lives today. So the goal, what the goal has been set? The goal has been set to get the cervical cancer incidence below 4 cases in all the countries per 1 lakh woman years. So that is the goal that has been set, and we need to work together to reach the goal at least by 2030. So where does we stand now? HPV vaccination has been available in India since 2011, but the marketing statistics show that less than 1% of the girls must have been vaccinated in the last 11 years. And a research survey conducted in December 2020 found that 52% of women are still not aware of HPV vaccination. 29.8% of women reported were being screened, and the prevalence of screening, again, it depends upon the education status of the patient, depended on the marital status, it depends on the geographical area, it varies with the geographical area, and it depends on whether she belongs to a rural or urban area, like that. So still only 30% of the women were getting screened in India. And the diagnosis of carcinoma cervix was usually based on opportunistic screening, either after the onset of symptoms or opportunistic screening when she comes for some other illness to the hospital. So this is the prevalence of cervical cancer screening among women aged 30 to 49 years as per the National Family Health Survey of 2015-16. This was a district-based survey. So what's new? We have the indigenous vaccine, the Cervavac. It got market authorization by the DCGI in July 2022, and possibly the vaccine will be launched by the end of this year. And we have the nonavalent vaccine available, the first gender neutral HPV vaccine. It is available. It has started becoming available in India. In USA and all, they have replaced this nonavalent vaccine as replacing the Cervarix and Gardasil, because it is protecting against more number of strains. And the SAGES review has concluded that a single dose of HPV vaccine delivers solid protection against HPV comparable to the two-dose schedule. What we are recommending is give two-dose schedule to the girls below 15 years, and more than 15 years we need to give 3 doses. But if you are able to attain the same immune response with a single dose, it would be a game changer, because you will be able to improve the coverage of the vaccine, and it will be very easy to reach the target by 2030. So there are so many, some of the RCTs have come, and the observational studies from India, Costa Rica have come with the result that single dose vaccine is having a comparable efficacy to the second 2 or 3 dose regimes. But still, it has not come in the guidelines, and we need to have more data to support the to switch over to single dose schedule. We have very big trials, very big RCTs on which are going on this particular subject. So once the results of those trials are out, possibly, hopefully, we may be able to switch over to a single dose schedule. So don't let cervical cancer stop you. You get screened and get vaccinated. We have all methods of prevention available for cervical cancer, for fighting cervical cancer. So we should all we should all work together, be it gynecologists, be it radiologists, be it community oncologists, all should work together. Then only we'll be able to achieve the goal, because we have a long way to go. As of 2021 data, globally, only 13% of the girls have got this vaccination so far in the target age group, and our goal is set at 90% of the girls by 2030. So we need to go a long way, especially for Indians. So with that, I conclude, and thank you for your patient hearing. Thank you.
That was Dr. Ramya Binesh, a consultant gynecologist and obstetrician from MIMS Hospital, Cortical, who gave us a comprehensive evaluation of CS cervix, covering the primary, secondary, and tertiary prevention possibilities, and she has given us a hope. Maybe what the smallpox eradication campaign did in the 70s, it may be possible in the cancer care with the vaccination that is available, that is capable of giving a message that cancer is totally preventable or totally curable. Is something like that is, I think it is possible for CS cervix. That's the message that Dr. Ramya has conveyed to us. And we have here 2 community oncology experts who have been part of this kind of community oncology projects, especially on CS cervix. Dr. Kalavadi ma'am and Dr. Jayakrishnan has done some significant work in this area on CS cervix. They are here as our panelists, and I would like to hear from Dr. Kalavadi ma'am and Dr. Jayakrishnan, their experiences on CS cervix in the Regional Cancer Center, the community oncology. Over to you, Dr. Kalavati ma'am first.
Thank you. We all know that the WHO announcement of cervical cancer elimination by 2030 to bring down the incidence of severe cervix up below 4 per 1 lakh population. In Kerala, especially according to the population-based cancer registry of our own institute, our incidence is lying between 6 to 8 per 1 lakh population. In nearly 7 per 1 lakh population on average. So I have been actively engaged in the cervical cancer prevention activities for the last 20 years actually. So initially we were doing a lot of pap smear programs, and we could detect so many cervical cancer cases and pre-cancers also. And nowadays we have shifted mainly to via-vili activities because of the limited availability of the persons to read the cervical smears and other feasibilities. So, but my dream is to shift to the HPV screening or even testing HPV for needed patients. Patients means women who have, maybe they have symptoms or they may not have symptoms. Women with certain preliminary cervical cytological abnormalities like ascus, atypical squamous cells of undetermined significance. These women, they have to be tested for HPV. Even that is not, I'm not able to do many times, because women who can afford, of course, they can go for HPV testing. But what about the majority of women coming to our OPD who can't, they don't have the ability to spend 1,000 rupees for HPV screening. So that is one question. I was thinking today, from the morning itself, even though it was a heavy, crowded OP today, my mind was behind this. WHO is saying vaccinate 90% of the girls. How we haven't started vaccination even for one child. We haven't given. Maybe some private hospitals are doing it, but not the government institutes, and it's not a widespread practice. And I don't know how we are going to get this this figure, 90% of the girls in that age group getting vaccinated above the age of 15 by 2030. And coming to the screening methodology, as I have already pointed out, HPV screening, that also is not happening. And our government of Kerala, they say that they are about to start HPV screening. They are about to start HPV testing. They will be starting shortly. And maybe if they are starting HPV screening or HPV testing, then okay, we can hope for the best. Then coming to the in RCC, now we are doing in our OPD, we are doing pap smear, colposcopy, and if needed, biopsy also. And but for the screening campaigns, now we have we are doing only via-vili, because we used to collect pap smears, because we but nowadays we have facing a lot of issues. After collecting so many pap smears, we have to, if we collect a single pap smear, if we collect a single sample from a woman or a man in a community, we are bound to give the reports in time. We are bound to give them the answer that your test report is this. But that we are finding, sometimes we are finding it difficult. So and in order to reach more and more women, in case of cervical screening, we have shifted to the viability methodology for the our outreach programs. And we do viability, and that is visual inspection with acetic acid and visual inspection with lubriciding. And after that, if we see any even mild or doubtful lesions in either in VIA, especially in VIA and VILI also, then we ask them to go to the nearest Talu hospital or district hospital. And in Trivandrum and Kollam, etc., we ask them to come to our own OPD. And in our OPD, we collect pap smear, and after that we do colposcopy. We have a very good colposcope, and if we come across any VIA positive or VIA and VILI positive lesions, then of course we can do the directed biopsy, and we can collect the biopsy from the specific site, and according to the biopsy report, we do the next, we go for the next step. So here also what I have to say is the gold standard is, we now the gold standard, we used to say that gold standard is pap smear. Even pap smear is cost effectiveness is there, but we don't have the infrastructure to do pap smear for all the women who want screening, who need screening. But then how can we say that HPV screening should be done for at least 70% of the eligible women in that particular category that is there? And coming to the third element, that is treating of the precancers and cancers. Now, since we are detecting only a limited number of precancers and precancers, maybe cancers we are detecting because they have symptoms. But in the case of precancers, many of them don't have any symptoms. And detected cases are being treated in certain centers. But maybe in that might be happening in Trivandrum, that might be happening in Calicut, maybe that might be happening in Ernakulam. But in other districts, especially in districts like Idukki and Wayanad, what is happening? But if one woman is being detected as having CIN1 lesion or low-grade squamous intraepithelial lesion, what is the next step? Usually they do hysterectomy. In many cases, they do hysterectomy. Some they may not go for any further treatment. Then, but in the case of CIN2 and 3 also, they may not be going anywhere. They might be waiting for they may not be going anywhere. And maybe after 5 or 6 years, they might be landing up in any hospital with bleeding PV and other symptoms of CS cervix. So that is what is happening now. And in Trivandrum, of course, we are we are working in a tertiary cancer center, so we have facilities for pap smear, then viability and colposcopy biopsy, and for HPV testing. Also, we do for only a very low number who really need HPV testing. Okay.
Thank you, ma'am, for highlighting the ground realities of achieving these magic numbers of 90, 70, and 90. All of us are aware of the ground realities in different districts and different levels of healthcare too. But one thing that Dr. Remia mentioned during her talk is, if we truly want to achieve the vaccination, the cost has to come down, and that is a very major development that has come from the Serum Institute, that is offering it for 250 rupees or less than that. That can be a game changer, and integration of it as part of the immunization schedule also can make a significant difference in that. But coming to the 70%, the screening of it's still happening at an opportunistic level. That is where I feel the gynecologists and the doctors at different levels of healthcare can make a significant difference in incorporating it as a opportunistic screening and make use of the best of it. But let me ask Dr. Danya KS here. She is a radiation oncologist. And what is the outcome of radiation oncology if you're detected in the early stages or late stages of what is the general what is your perspective on the use of brachytherapies that you have much, we are an expert in, and you would like to hear your views on the cancer survival rates in those cases.
Thank you, sir. According to my experience, up to stage 4A, we can cure the carcinoma cervix. If we detect the cancer in stage 1 and stage 2, we can assure the patient and the bystanders that we can cure it completely, and the recurrence chance is very less. If we detect the cancer in stage 1, the chance for 5-year survival, that means the most of the randomized trials are run based on the 5-year survival, but they will survive for more, 10, 15, 20 years they will survive. And 5-year survival studies show that if we detect the cancer in stage 1, we can cure, and the survival is more than 95%. And if we detect the cancer in stage 2, the chance for 5-year survival, the 5-year survival is only 70 to 80%. And if we detect in stage 3, the chance for survival is only 50 to 60. And stage 4A also we can 40 to 50. And up for more than stage 4A, that means if we detect the cancer in stage 4B, that means if we detect cancer with distant metastasis, the chance for 5-year survival is less than 20%. So our aim is to detect the cancer in stage 1 and 2. That is our aim. So we can completely, stage 3 means the natural history of cervical cancer, how the cancer cervix spread. First, the tumor confined to cervix, and the local spread, that is the next thing. The tumor spread to near to vagina and parametrium, and after that it spread to lymph nodes, and after that it spread to anteriorly, it spread to bladder and rectum, and it produces hydronephrosis, and patient will end up in uremia, that is renal failure. That is the end stage. That misery is, we can't see the patient because patient suffering like anything. So the most of them neglected, and most of them are in most of the patients are in more than 60 or 70 years of age, and they will come with the stage 4B disease because of their negligence and their open minded. Most of them neglected and came to us for treatment. Then we can offer only the palliative treatment just to control hemostatic radiation, to control the bleeding. That is at that time we can offer only palliative treatment. So if we can see the patient in early stage, we can cure the disease. That is the thing. Most of them we can cure, and the evaluation part is very important, because how we can evaluate and how we can diagnose the cancer in early stage, that is very important. Nowadays FIGO staging workup gone, because there are many advanced techniques are there, advanced MRA, and there is no need to do colposcopy, cystoscopy and proctosigmoidoscopy to diagnose whether there is any bladder infiltration or rectal infiltration. We can just do the MRA with the contrast. We can see bladder infiltration, whether there is any bladder infiltration or rectal infiltration is there. So after doing a biopsy, we can directly go for these diagnostic investigations and stage and treat. And first, before starting treatment, we have to know whether there is any parietic infiltration, parietic lymph node infiltration. That is a bad sign. So before going to that, we can do the screening of abdomen also, and diagnose whether there is any metastatic lesions before starting the treatment. so that the delay of treatment we can avoid, and we can treat patient as early as possible. And nowadays, early stage, if we detect the cancer in early stage, we can finish the treatment with surgery alone. That is up to stage B1. The surgery is the best line of treatment. We can finish the treatment with one mode of treatment, one line of treatment. There is surgery is enough. And if the more than B2, the concurrent chemoradiation is the line of treatment, followed by brachytherapy. That nowadays the treatment techniques are modified, and that toxicity based on the treatment are reduced, because more advanced linear accelerators are came for the treatment purpose. So we can reduce the dose to nearby structures like bladder and rectum. We can reduce the dose to rectum and bladder, and can give radiation to the tumor and the required sites. And after that, we can push further dose with brachytherapy. What is the advantage of brachytherapy is that to cure the cervical cancer, we have to push a high dose to the tumor. That is almost 85 to 90 gray. We cannot give radiation with the external beam. External beam radiation is we have to give a 50 gray, 46 to 50 gray to the pelvis to control the lymph nodes and also the cervix and parameter disease. We can control the disease with the external beam RT. But gross disease, we have to push very high dose to the tumor. At a dose of 85 to 90 gray, we have to push the dose to the tumor. Then only we can control the disease. So after 50 gray, after external beam radiation, we can use brachytherapy, intracavitary brachytherapy. So through this, the advantage is that brachytherapy follows inverse square law. That means distance increases, dose fall-off is very fast. So we can spare the normal structures. At the same time, we can deliver very high dose to the tumor, and we can reduce the toxicity and can attain the tumor dose. And we can cure the disease. That is the advantage of this brachytherapy. That is a beautiful and wonderful technique for the cervical cancer. So that is the thing. Even though it is a stage 4A, we can cure, but most of them will end up in renal failure and we have to do stenting before starting the treatment. And some have hemoglobin will be at 4 or 5 due to this severe bleeding and anemia, the renal failure. That is the more complications associated with cervical cancer. So to prevent that, you should we have to
Thank
diagnose
you.
very
Yes.
and
Yes.
if you find it, please try to motivate them, and all the society should support them to treat the cancer, and that treatment should be completed within 8 weeks. That is also very important. If we prolong the treatment more than 8 weeks, that treatment failure will be very high. So the treatment, the duration of treatment only for the cervical cancer is only for 8 weeks. There is no need to give any maintenance treatment or any drugs after this the radical treatment. So motivate them to take the treatment and support them and motivate. That is the thing.
Thank you. Thank you, Dr. Danya, radiation oncologist from American Institute of Oncology, Baby Memorial Hospital. She has given the hope, even in cases of advanced stages, unless it is too advanced beyond stage 4, even stage 3 and stage 4 and early, and of course the early stages of stage 1 and stage 2. With the help of imaging biomarkers, staging can be done very easily now, and with MR playing a very significant role in imaging, and of course with the modalities like in radiation oncology, in brachytherapy and all, giving wonderful results. But our focus of Kerala Cancer Crusade and Cancer Literacy Mission is to downstage the detection of the CA cervix detection rates. So we need to have a very clear-cut strategy here. One, and the primary prevention of vaccination being promoted and made an integral part of the national immunization program, or the government's taking a lead in that, because the COVID has given us enough confidence that some of these vaccination measures that can be highly effective and can give real good results. And maybe in cancer prevention, CS cervix vaccination may be a very, very important one that will be giving one of the first and best results possible and against the drive against cancer cure or a cancer eradication. Let me ask Dr. Jayakrishnan, the additional professor of community oncology in Regional Cancer Center, Trivandrum. Dr. Jayakrishnan, we have been talking about NCD clinics as a part of the Kerala Cancer Crusade. That is a non-communicable diseases clinics in both government as well as private sectors. Government is already coming out with a Shaili app, which is with the help of ASHA workers. They're collecting data on the high-risk groups or high-risk individuals who are more prone to have breast cancer, CS cervix, lung cancers, and they're collecting a lot of data, variables that which can be used both by the private sector and the government sector for instituting screening protocols. So, and one of the ideas that is mooted as part of the Kerala Cancer Crusade to have a eco-friendly or a patient-friendly NCD clinics in the private and establishments too, including at different levels of healthcare, secondary and tertiary levels of healthcare. Dr. Jayakrishnan, what kind of a screening protocol do you suggest for CS cervix in these NCD clinics? Do you want gynecologists to be an integral part of that NCD clinic, or what are your suggestions on? What are your thoughts on that?
Okay, first of all, thank you, Dr. Richa, for giving this opportunity to take part in this session. And it was a very wonderful talk and a very beautiful discussion going on in between. And regarding your question, I think this eco-friendly, the term itself means, the patients or those subjects have to take off their apprehensions regarding detection. So if you say about cancer as such, it will be difficult for the people to come over and get a screening done. For example, if you look into the National Family Health Survey round 5, you can see in India, hardly 1 to 1.5% of women had undergone screening for cervical cancer. So I think to attract people for screening, I think the best thing is to go for an opportunistic screening for NCDs as such. And regarding the health service team, what they're doing is that, am I audible?
Yes, very much. Please go ahead.
So what they're doing is that they are asking the ASHA volunteers to go for house-to-house survey with a set of questions, and which is a part of NCD. And within the NCD question, there are sort of 10 questions regarding cancers, like oral, breast, and cervix. So if there is sort of a score of 4 and above, as per the questionnaire, a score of 4 and above, they will ask the patient to come out to the family health center or primary health center. So I think even in a basic detection clinic or an eco-friendly clinic, the best thing we can do is that at least we have to train doctors. We have to train the staff nurse, like the mid-level service providers of the National Health Mission group. And training is the first part which we have to do. And with the basic training, even if we can give it to the nursing group, like the BSc staff nurse or people like that, I think that initial level of screening can be done at these clinics. So what we say is that the government centers are more of crowded, so it's a bit difficult to do this. I think we need a public-private partnership as far as NCDs and in particular cancer is concerned. So we need to train people. We need to train people in various levels, like in the nursing group. We have to train the GPs, at least to take a pap smear or to do a VA, and from there we can channelize that person to the higher specialist, like gynecologists and others like that. So the whole idea is to decrease the screening interval and diagnostic interval, and if you can reduce the interval, of screening and diagnosis, and the final diagnosis, you can direct the patient for the treatment. So that's the whole idea. So training at various levels, we can start a clinic with focus on opportunity screening for cervical cancers, breast cancers, and oral cancers. And unfortunately, these are the 3 common cancers in India and also in Kerala, which are completely, curable if you detect early. So 2 components we have to take care of. We have to increase the health literacy or cancer literacy among the public and also among the medical fraternity and the paramedical staff, and then channelize the person for higher treatment or higher investigation.
Well said, Dr. Jayakrishnan. That is one of
I
the aims.
One question to ask, because I was just looking at Dr. Renya's excellent presentation. So I was just wondering, Doctor, you mentioned about the mortality, that is out of 1,23,907 cervical cancer patients in a year, 77,348 deaths are happening. That is almost 62% mortality. And now Dr. Denya has told that even at stage 4A, 40 to 50% survival can be achieved. So I was just wondering, still, why this much
disparity?
Happening even in India. And what's your take on it, Dr. Denya? Or Dr. Denya?
Might be because, sir, they are not completely following the treatment protocol, whatever has been advised, that what Danya was pointing out. You have to stick the prescribed treatment protocol, then only you will be able to provide the whatever survival we have given. Like for stage 3, it should be 40 to 50% survival, means they have completed the prescribed course of treatment. Maybe many of the patients were losing during the course of treatment, because of some side effects and all. Maybe they are switching over to some indigenous treatment. So all those plays might have come in between, and that may be one possible reason we are not having the expected outcome, even though we are treating.
What is the distribution of this data from the various parts of India? Is it a low resource setting or a place where it's a rural setting that has got more mortality? Any ideas on that?
This data is taken from the Globocrat 2020. The number of deaths and the total number of incidents of cervical cancer have taken from the Globocrat data. Actually,
I think, Jayakrishnan, we have to look into the distribution of that data into rural and this thing. Maybe one component, I feel that there could be the facilities, treatment facilities, especially the advanced facilities that Dr. Danya and all are talking about. They may not be accessible for a significant population who have been affected, especially in different parts of India where we know the healthcare facilities are not as good as that we are getting here in Kerala or in some of the developed parts of the country.
Maybe that's
most of the centers are there. Brachytherapy services also. That is the reason.
Yeah, brachytherapy may not be available.
Most of the centers have these external beam radiation, but brachytherapy services are very low in most of the centers. That is the reason why most of the cervical cancer fail during the treatment, and after the treatment they fail, because we cannot push high dose 85 to 90 grade to the cervix without brachytherapy. So if there are the expertise not there, it's very difficult to treat the cervical cancer.
Right. That's a point well taken. So, Dr. Yeah, Jason, please.
If you look into the data now, you can see that even in India, I think now the leading cancer is breast cancer. I think around 28% of breast cancers, then cervical cancer. So if you look into the Kerala data also, in the 80s and 90s, even in Kerala, the common cancer among females was cervical cancer, and now it has come down. So I would like to know more, in Dr. Renya's presentation, she mentioned about 3 or 4 things. Like one is improved socio-economic conditions, maybe one of the reason. Then maybe a screening component is there, and hysterectomy also. So which one will be the most, if you look into the Indian context as a whole, we can also see that even in India also, the cervical cancer incidence has decreased from the first rank to the second rank. So is it because of the improved socioeconomic conditions, which is the main reason for it, or is it because of screening or hysterectomy?
In Kerala,
I don't.
in Kerala, the one thing is the improved socioeconomic status, and then the literacy rate of ladies, and the age of marriage that is slightly increased compared to other states of India. It is more than 20 anyway, and multiple partners and all those things are also less compared to, and the improved health of the ladies, and the screening also. And the one thing is that in Kerala, the approach to doctors or the hospital is more compared to, say, approach is more compared to other states. So they can reach the doctors and meet them, and then they can go for a screening and also hysterectomy rate. That will reduce the incidence of CSRVs. And
But generally in India also the incidence of CS cervix has come down and CA breast. So it's a general improvement. Kerala alone is not the factor there. That's what Jagashan was pointing out.
Another thing is that breast cancer is the incidence of breast cancer is increasing because the risk factors for breast cancer is increasing. On the other hand, the risk factors for cervical cancer is decreasing. So maybe the number of breast cancer cases is rising. That is one possible reason why the breast cancer has become to the first place and cervical cancer has become.
Right. I got it. Yeah, that's fine. So we have.
Actually,
I want to add one more.
Actually,
please.
About the vaccination. Because in Kerala, most of them can afford the vaccine, but they don't know about the vaccination. So we have to use all the medias to educate the public, and they should know that there's a vaccine is there. Most of them don't know that there's a vaccine is available. And we have spending a lot of money for marriage of a girl, and for birthday also we are spending a lot of monies. So you can utilize that way. So as a birthday present, give a vaccine to your girl. Or before marriage, as a dowry, before going, you give this vaccination to your girls. So in all those ways, we can educate the public, because the public unawareness is the main reason for this vaccination, in Kerala especially. And about the screening program, here the people are, more 70% of the people are depending on the private hospitals. So government hospitals are also there and private hospitals are also there. Most of them are going to the private hospitals. And the screening is, you can say that is nil. So you can use that opportunity, because CIN does not have any signs and symptoms. They don't have any signs in case of CIN. So they won't come for treatment. If they come for some other purposes, with our routine perspective examination, we cannot diagnose CIN. So we can use a VIA in all the clinics, all the gynecology clinics, instead of doing a perspective examination and do a VIA. So detect the lesions. And in that setup, if possible, take a biopsy also. It's possible in our clinic. You can take a biopsy there and then treat. If it is CIN, you can treat them with cryotherapy or thermal ablation. It is available in most of the hospitals. The cryotherapy is available. Treat them. So in that way, if all the private hospitals and private gynecologists are doing this VIA screening, it's an opportunistic screening as a VIA, and the same sitting biopsy, and they can treat them at the same sitting. In that way also we can reduce this incidence of cervical cancer. That motivation is important.
Yeah, one point I just want to add is we need to have some focus on this, because in a gynec OPD, people come with different kind of this thing. So unless and until we need to have a NCD clinic where important cancers are being screened, I think the chances of detection rates also goes up. But otherwise, just like your Foxy's Gynec Onco committee, you need to put some guidelines for all gynecologists to have a mandatory check on all this screening of CS cervix, which I'm not sure which is possible for you or not. But unless because gynecologists, I feel, is getting a real good opportunity for screening for breast cancer and CS cervix and all the gynecological malignancies. Many a times I have seen patients coming with stage 3 and stage 4, see breast cancers or this thing. They might have had several consultations with GPs, physicians, surgeons, or gynecologists, but unfortunately there is no focus on the uh, cancer screening protocols, which has resulted in the advancement into stage 3 and stage 4. This is one area that all of us doctors has to pay more attention, and I think this gynec onco committee is paying a special attention, and I think it has to be made a mandatory screening protocol for especially by gynecologists, and also in the NCD clinics that Dr. J. Krishna has noted, where we can use the help of trained nurses or paraclinical staff to go for VIA and all these things, so that of course the workload can be a little reduced, because there are other kind of activities also happening in the gynec OPDs. I think we are coming to the end of this session, and before we wind up, I think there are a lot of good messages that have come out. This is one cancer. We have to give hope to the society that cancer is curable, or cancer is something that, because if you look at the epidemiological transition in the non-communicable diseases around the rise in many parts of India, especially in the southern parts and western parts of India, and many parts of the central India also. And of course, these kind of diseases like lifestyle diseases or non-communicable diseases, the diabetes, hypertension, and cancers, and the longevity is also increasing. These are there on the rise, and it is high time. And now people are comfortable living with diabetes and hypertension, and it is high time to live with cancers too, in the sense we have to give the hope that cancers are curable, and maybe CS cervix is one cancer that will truly give that message to the community that cancer is curable and it can be eradicated. So with that message, let me conclude today's session, and by thanking all the speakers and panelists, Dr. Ramya Binesh, and the chief guest today, Dr. Jeena Baburaj, who stayed with us till the end of this program, Dr. Danya KS, the radiation oncologist from Baby Memorial Hospital, Calicut, Dr. Kalavadi ma'am, the associate professor in community oncology of Regional Cancer Center, Trivandrum, Dr. J. Krishnan, additional professor in community oncology, Regional Cancer Center, Trivandrum. And once again, thank you all. I also wish to thank Dr. Avni for having organized all the speakers and the panelists today. I was an accidental moderator today. It was Dr. Avni who was supposed to conduct this program, but unfortunately she was not well and I had to take charge. So thank you all the delegates once again. We had a wonderful session. Tomorrow we will be meeting again at 8 o'clock for screening of head and neck cancers, and Dr. Santosh Kumar will be talking to us, and a whole lot of panelists will be discussing about, because we have realized that breast cancers, the cervical cancer, and the head and neck cancers are the 3 most common cancers, and that we need to fight in this Kerala Cancer Crusade against these 3 cancers. With that, once again, thanks Soumya and the entire MedPiper team for the technical support, and all the delegate once again for attending this session. Thank you very much and good night.
Okay, thank you. Thank you.
Thank you.